Well, thank you all. Hopefully some of what I can provide over the next hour or so may be useful or at least hopefully moderately interesting. I'm really going to look at it from kind of an applied standpoint. So a lot of my work these days is with the World Health Organization, the United Kingdom's Department for International Development, the U.S. AID, which is the foreign development funding mechanism of the U.S. government. So how do we either explicitly or secretly try to get in anthropology and some of the innovations from social neuroscience as well to the growing field of global mental health? Just from a disclosure standpoint, here are the main funding mechanisms for the research I'll talk about today. And all the photos that I'm using are with the participants' permission, and that's very important because we're going to actually talk a lot about photography. So why is this stuff important? Well, if we think about access to quality mental health care, for every one individual in a high-income country like the US, Canada, or parts of Western Europe, there are 4 other individuals who don't have access to minimally adequate care. If you take one person who has depression in a low and middle income country, there are 26 other individuals living with depression who do not have access to care. So there's a huge treatment gap out there with regard to access to services. Now, as Dirta knows well, and some of you in the room may be familiar with, the big push from the World Health Organization, the British government, and some other institutions has been to say, we're not going to get anywhere by trying to fund more and more psychiatry, clinical psychology programs, because it takes so long to set these up. Individuals only serve a small number of persons, and very often, when these are done in low middle income countries, most of those individuals that get training leave. There are actually more Nigerian psychiatrists in the US, Canada, and the UK than all doctors in Nigeria. So one of the problems the WHO has noticed is that often when individuals get these skills, they leave the country, which is understandable given humanitarian issues and other concerns, but it isn't a long-term public health solution. So the idea is to engage in task shifting, also referred to a little bit more diplomatically as task sharing. The idea of, in a place like Nepal where I work, or Liberia, Ethiopia, Uganda, could we train up individuals who might be a community health worker or a health tech or somebody else in the health system to be able to deliver mental health services? Or could you even extend beyond that and train a religious leader, a teacher, even a police officer to be able to do things that a social worker, psychiatrist, or psychologist might do here? Unfortunately, over the past 10 years of deploying this approach, we're finding that in many cases we're not actually shrinking the treatment gap in the way that we want to. Some of the outcomes from Kenya, Ethiopia, Malawi, and Nepal show that a very small number of individuals who live with mental illness are actually getting detected and entering into care when these programs are initiated. So there are a host of reasons that are involved in this, but the one that I want to focus on today is stigma. Now, stigma is very important to me because, as Lawrence was saying, my early work was around child soldiers. And we found that even though child soldiers in Nepal had relatively high levels of trauma, some child soldiers, when they went back home, had very low rates of PTSD, low rates of depression, low rates of anxiety, and other mental health problems. A child with a similar burden of traumatic experiences going home to a different community tended to have very high levels of psychopathology and distress. And when we began to tease this apart, it was really because of the stigma that they experienced. So when they came back to their community, if there was high stigma, they didn't recover from their traumatic experiences. And this has been pointed out again and again, that a lot of the impairment in quality of life of people living with mental illness is not just due to the psychopathology of that disease, but the position that that individual holds in society. So for some individuals, the experience of being stigmatized for having a psychotic condition may be even more severe than actually the experience of that condition. And I was really bummed to miss Tanya's talk yesterday, so I hope that that covered some of these issues around the cultural perceptions around psychosis that influence the societal treatment. So what we sought out to do was to be able to say, how can we look at stigma and the way that people with mental illness are treated in the community and in the healthcare system to try and improve the quality of life and actually to improve the quality of services. So stigma is important within a health setting for three key reasons. That a health worker, who's let's say a primary care worker, a community health worker, or a health tech, who's asked to take on mental health services may not be likely to do so because of the stigma, the discrimination and prejudice that they have towards a person living with mental illness. That if I as a health worker carry that stigma with me, I'm less motivated to learn about mental illness, how to diagnose and treat it. Even if I learn about it, show up at a training because I was told to, I'm less likely to go back and deliver those services. And if I have stigma, probably when I'm delivering those services, the quality, the adherence to evidence-based practices, and just the humane treatment of another human being is going to be relatively low, suggesting that even though I'm now getting services, I'm not going to benefit from them because they're not appropriate and I'm being stigmatized in the context of that setting. So as Lawrence was saying, I'd like to do a quick kind of world tour of some of these projects and show how social neuroscience theory is informing how we're trying to tackle stigma and thus improve mental health services around the world. So I'll actually start with Liberia and a project that's been going on there for the past 10 years, first looking at mental health after the 14-year civil conflict, and then some of the mental health issues related more recently to Ebola, and talk about the idea of can we reduce stigma simply by raising awareness and increasing the knowledge related, the biomedical knowledge related to mental health. Then kind of circle back to the US and work with my mentor at George Washington University, James Griffith, to talk more about some of the theoretical frameworks that may help inform different types of models that go beyond a knowledge approach to reducing stigma. From there, I'll spend the majority of the talk about the idea of collaborating with service users, people who live with mental illness who are seeking treatment in Nepal. I'll also bring in some other examples of that work that we've done in Uganda and Liberia as well. And with regard to that one, I'll also take a little bit of time to tease out some of the methods that we're using, complementing some of the things that Jeff discussed this morning. And then we'll end up in Ethiopia and talk about the idea of reducing stigma not only at the individual level, but at the system of, at the structural level to ultimately help improve the way that health workers treat people living with mental illness. So if we look at the majority of public health campaigns around the world, they've often been framed with the idea of if we just educate people about the importance of hand washing, of delivering a baby at a hospital, of rehydration when somebody has a diarrheal disease, of air pollution in the home because of cook stoves. If they just knew this information, their behavior would change. And that same model has been used with a lot of resources throughout the history of global health in psychiatry as well. So our first work in Liberia was actually kind of test out this model and see, did it work in the context of a low-income country, post-conflict setting, or were there some barriers to that type of approach? So Liberia, West African country, had 14 years of war, which also led to violence in neighboring Sierra Leone as well. At that time, almost 1 million people displaced, hundreds of thousands were killed as well, and throughout all of this, very low access to mental health services. So after the war and the violence ended in the early 2000s, the Carter Center, which typically does more public health infectious disease work, decided to invest in Liberia over a 10-year program to help improve mental health services. So this had 3 arms associated with it. One was, let's go in and train primary care workers, including nurses and physician's assistants, to be able to treat mental illness. Let's also address stigma, seeing as that's probably a huge barrier, and then throughout that process also try to advance policy as well, with the idea that once this initial program has ended, we want to make sure that it stays in place and is instantiated in legislation and in funding within the Liberian government. So around 2010, so now 9 years ago, we did our first kind of ethnographic and qualitative assessment of the experience of mental illness for individuals living in Liberia. And one of the important things, and is very common in the work that Jeff does and many others looking at global mental health and cross-cultural psychiatry in international settings, is the idea of explanatory models. Can we get a sense of how individuals talk about mental illness and what they attribute in terms of the causality? So we found that there was a number of different idioms. Almost all of these idioms were very stigmatizing. So that was a first barrier we identified. There wasn't language to kind of acceptably talk about living with mental illness. And then in terms of causation, because of high rates of substance abuse, they often attributed this to drugs and alcohol, witchcraft, demonic possession, spoiled medicine law, and war trauma. And one of the things that we found at that point was that health workers often said, it's not my place to treat someone living with mental illness because this is God's will, or this is African science being traditional beliefs. And if I were to do this, I would then suffer ramifications myself. So this person has been cursed by God because of bad things they did. That's their punishment. If I take that suffering away from them, I will then incur that, or my family members will. So this was often used as the rationalization with regard to why health workers didn't engage in mental health services. So we, in our qualitative work, also identified low levels of knowledge about mental health amongst the health workers, high rates of maltreatment, being tied, chained up, or just kicked out of health facilities, stigmatization not only of the patients, but also of family members. And we even heard that, well, if an individual comes in as a nurse or even a mental health specialist and provides that care, they're going to get mental illness true. So there was even stigmatization against other health workers engaged in mental health services. Lack of financial investment and training, almost no availability of psychiatric medications for treatment, and negative media portrayals. And one of the studies we did was to take both online and print newspaper clippings to just look at how mental health was described in the popular press. So this is from one clipping that says basically that if an individual smells the flatulence of a person with mental illness or a developmental delay, that they will then suffer that same experience. So the idea was, okay, if we know there's low knowledge, can we start with the knowledge piece and then see if everything kind of trickles down and benefits? If we educate health workers more about the causality of mental illness and the fact that it's treatable, will we see some type of behavioral change? So we used this standard public health framework, often referred to as CAP, or Knowledge, Attitudes, and Practices. The World Health Organization for decades now has a World Mental Health Day, typically in October. And as part of that, the World Mental Health Foundation puts out materials that can be used to raise awareness and educate the public. So we collaborated with them to develop a whole series of Liberia-specific radio shows, call-in programs. There were wristbands, billboards. So we did these activities and then followed individuals up 6 months later to see if there was a change in the perception about mental illness and a change in knowledge. So we followed, originally there were about 350 people, and we met them in 6 months. From that, one of the positive things was we were able to follow up about 3/4 of the individuals, and that the majority of them actually remembered seeing something or hearing something about that. So the exposure itself sunk in to some degree. But what we found was that after that period, if we looked at these individuals 6 months later, there was actually no change in any of the attitudes related to people living with mental illness. So social distance is a very commonly used scale. It can be used for stigma related to race, to sexual orientation, to religion, to political party, and as well as mental health. So we gave these vignettes at the beginning and then again 6 months later and found that there was no difference in terms of how people were perceiving mental health. So even though knowledge and awareness and kind of remembering those messages and the content of those messages was there, people's attitudes hadn't actually changed. So what we decided to do is take a step back and say, if we go with this traditional public health model of just trying to change knowledge and it's not working, is this just a one-off, or is this consistent with barriers others have identified to actually changing attitudes and behavior? So circle back to more Western-based literature around stigma, neuroscience, and mental illness. So there's a stigma researcher at the University of Indiana, Bernice Pescasolido, And she looked at, in the US, the decade of the brain and this concept of a disease like any other, which was an initiative to look at neuroscience and genetics and try and educate more of the American public about the biological roots of mental health, with the idea that if people invested more in a kind of a neurobiological causality model, we would see a change in attitudes. So what she did, she looked in 1996 and again in 2006, and this showed that there was a significant change in individuals moving from more of kind of a character, life experience, just general ups and downs of life, moving away from those types of models and investing more in ideas around a chemical imbalance, a genetic abnormality, or some types of neurobiological abnormality. But in that same large study, she showed that there was no association with actually then changing attitudes towards individuals with mental health problems. So there was no improvement in terms of believing that people with mental illness were violent to themselves or other, no increased likelihood that you would befriend somebody who had mental illness, no increased likelihood you'd be willing to work with somebody who had a mental illness. So even though there was a clear public shift in the attribution of mental health over that period, the attitudes themselves weren't changing. And if you think about somebody with depression, simply naming it something different might not always get the job done. And this is pretty consistent with a number of studies that have been done now, suggesting that simply by changing a causal attribution, even amongst a highly educated population, doesn't guarantee that attitudes and very low likelihood that behavior actually changes. Similarly, this is what we've found with a lot of the WHO global initiatives related to mental health treatment. That if you look at primary care workers who have been trained in 4 different countries and have a better understanding of the causality of mental illness from a biomedical perspective, and even are aware of effective treatments, that attitudes don't change. Ethiopia, Nepal, and South Africa, primary care workers before and after WHO training showed no improvement. And actually in India, the attitudes got worse from a statistically significant perspective. They were more likely to say that people living with mental illness were violent most of the time after they received the WHO training. So another leading researcher in the field of stigma, Patrick Corrigan, did a meta-analysis about 7 years ago to look and see, is this consistent? Is this issue that education isn't producing the changes we need? Can we find that across the majority of studies? And his meta-analysis revealed that when you look at education campaigns, there's almost no overall positive developments in terms of attitudes and behavior. However, if you take individuals, police officers, primary care workers, teachers, the general public, and you have them spend time with people who live with mental illness, that social contact seems to have a large difference in terms of attitudinal change and at least some potential difference in behavioral change. Very few studies have actually looked at behavioral change, so it's hard to draw major conclusions there. But so this says, okay, changing the cognition, changing the ideas related to how I want to explain mental illness isn't producing these behaviors, but spending time with people with mental illness, maybe that seems to be producing something. So let's take a step back and look at what the neuroscience of stigma tells us. And a lot of this far predates any neuroimaging studies with the field of social psychology and contact studies that were done as early as like the 1940s and 50s, a lot around the integration of schools with regard to black and white students in the US. But it's the idea that there are different affective processes going on that lead to stigma. So the most important, probably affective part is the idea of a perceived threat, that an individual stigmatizes against another group because they feel unsafe, that there's some kind of danger signal going on. And I'll take a moment in a few slides and talk about that's not just danger to one's life, but it could be danger to one's social status, other things like that. That feeling of danger is much more likely to happen if an individual is already feeling anxious because of the context they're in, because of the demands, because of the type of sociocultural environment at that moment when they're stigmatizing. What seems to happen then is once there is that activation in terms of threat, that an individual is much less likely to follow a pathway in terms of responding empathically. So mirroring processes, emotional contagion, that the more threatened an individual is, the less likely those processes are to occur. And another is some of the increasing work around the neurobiology of hope. Some of these not avoidant, but actually going towards or engagement behaviors, those are also shut down by these feelings. Now there's two ways that this happens. One is the idea simply you're immediately threatened and so you feel this way. But then the idea of stigma is that this becomes generalized over time. So that I may see an individual that I've learned through socialization, through the media, through whatever it may be, and then simply seeing that individual in the future because of some type of physical stigmata, their appearance, their language, whatever it may be, the context, their behavior, that I'm immediately going to go into that threat state and therefore not empathize and not care for them. So if you're a health worker in a low-income country and you have very little training or resources to deal with somebody who has a mental health problem, and you've heard a story of somebody else who came in who was violent and acting in a certain way, and they were given a label of crazy or mad or psycho or whatever it may be in the local language, and somebody else comes in and already you begin to think that this might be a mental health issue, you can imagine that that empathic response is rapidly dropping, which is probably why many of these WHO programs aren't achieving the intended goal. So my mentor at George Washington refers to this idea that stigma is a normal function of normal brains. And what he advocates is to move away from what's typically being advocated in the training of psychiatrists and psychiatric residents, and which I'm now applying to international health workers at primary and community care levels, is to move away from the actually recommendations by the American Board of Psychiatry and Neurology in the US that suggests that if we teach residents to explain using neuroscience and neurobiological and genetic terms to their patients and families, that there will be less stigma. And that's actually one of the current psychiatric milestones. So my mentor Griff's recommendation is actually we need to teach people about the neuroscience of stigma to help health workers change their behavior. So in that model, what Griff's laid out is that we need to think in the course of a health interaction, first, what is the stigma mark that's being perceived that then leads to that alert of that this is threatening in some way? Then the idea that this person is different than me in some way, and that's the activation of the dorsal anterior cingulate cortex. Then once that has happened, we basically have less prefrontal regulation of information processing, more of a reactive response, a threat-based response, which then leads to an aversive behavior and the withdrawal of empathy. All right, so how do we take that model and then go back to a health worker in Liberia or Nepal or somewhere else? Well, the first thing is to be able to map out what are those types of threats that are triggering the system. So the obvious one, and the one that most of the work has been based on, is the idea that these are survival threats. It's the idea that that patient, that individual with mental illness is going to be violent towards me and I might get hurt, my colleagues might get hurt, so the idea of peril threat. In some cultures around the world, it may also be that I may catch that mental illness from that individual and then either live with the mental illness or I may die. For example, in West Africa, epilepsy is thought to be contagious, and epilepsy is considered a mental illness. So the idea of I don't want to catch mental illness, therefore I feel threatened, therefore I'm going to stigmatize and withdraw my empathy. The other thing that's really important, though, and this is where sometimes thinking about professional roles can be very helpful that cut across cultures, is also the occupational or professional threats. So this is the idea that I also am going to feel threatened if my status in the health system, my status as a health worker in the community gets compromised in some way. And there are at least two key types of occupational threats that have come out of our qualitative work and other prior social psychology. So one is the idea of disruptiveness stigma. And you can think about this whether you're a health worker or a teacher or a parent or a shopkeeper. It's the idea that when I spend time with somebody living with mental illness, that's going to impact my other work. So imagine that I've already got to see, 30 patients in the course of the day. Somebody comes with mental illness. I don't want to spend any extra time with them. I'm going to be late for everything else. Or the idea of I'm a surgeon. I have to go and do all these procedures. I don't want to deal with that patient who I'm going to have to take the extra time explaining to or addressing their care in some fashion. If I'm a community health worker and I've got to go out and just vaccinate everybody in the whole village, I don't want to have to deal with somebody who might be more anxious, more afraid of getting those services. The other part that's really important is that most physicians have a God complex, but even community health workers feel that they play an important role in the community, that you're actually able to help people and impact their lives. And they're very invested in that social image. Therefore, if I were to engage in something and I don't know if somebody's going to get better, I might feel that my identity is threatened, this idea of helplessness. I don't want to treat something that I don't know that I can't address. This is why in both high and low income settings, many people are afraid to discuss suicide because they feel like, how can I make a difference? What am I going to do? I don't want to open up that can of worms. So these two things also trigger a threat-like response. And then the third, and these are things that individuals have spoken about previously, are more of those social threats. I don't want to be seen by the community as somebody who's spending time with mental illness. And then they might say, oh, I'm going to get it, or I'm going to act strange, or what's wrong with me? And what we see in many settings around the world is if one health worker takes on mental health in a primary care setting, suddenly they don't refer to them as psycho or mad or some other stigmatizing term. But if let's say it's Ben that's taking on those patients, they're suddenly Ben's patients. Or if it's Jamal that's taking on those patients, they're suddenly Jamal's patients. So suddenly that health worker's identity gets mapped onto the care they provide to people living with mental illness. All right. So here's the model that we're trying to now integrate into our work and see if we can actually change behaviors. So rather than saying, let's educate people about the cause of mental illness, let's actually try and get at these types of threats, try to improve empathy, and then ultimately lead to more helping behaviors. So from a medical anthropology standpoint, we say these are the three things that matter most to a health worker. The idea of staying alive, the idea of doing well at my job, and then also being respected in the community. So we need to make sure that any anti-stigma intervention is going to tackle those three parts. The next then is this idea of social psychology. We know that just educating people isn't working, but spending time with them, this idea of social contact, seems to help based on other social psychology studies. So we need to have a social engagement component to then reduce these three threats. And then social neuroscience talks about how important it is to have an affective response throughout this. We have to promote hope. We have to minimize some of these in-group, out-group differences for this process to be able to be successful. Okay, so we have a theory. Time to go try it out. So in Nepal, we've started a program called Reshape, Reducing Stigma Among Healthcare Providers. And the idea is to partner with people living with mental illness using these concepts to be able to facilitate their interaction with primary care workers getting trained to see if we can reduce stigma and then ultimately improve the quality of clinical care. So we use a technique called photo voice. It's the idea of how do you create a shared experience between somebody living with mental illness and a person who's a healthcare provider who may have no interest whatsoever in interacting with them and see them as very different types of people. So photo voice is the idea of using visual images to tell stories. It's the idea of trying to create a joint kind of understanding of certain symbols between a health worker and a service user so that that health worker then feels invested to provide care later on. So what's done with photo voice, and this has been used in a whole series of global health, of projects in high-income countries as well, it's to work with individuals who might have low literacy or no literacy at all, to be able to tell their stories, to craft a narrative. And this is so important because in many cases, to date, when people are doing social contact interventions for mental health, they often just invite somebody living with mental illness to come in and tell their story. You can think of this in medical schools or in nursing schools. Come in, tell us what it's like to live with a mental illness. But people aren't prepared ahead of time to be able to deliver those narratives. And what we know from both an anthropological and a social neuroscience perspective is there needs to be actually a narrative arc. there needs to be a way that that story connects with people from the beginning and then moves them along that pathway, just you might think about in terms of like symbolic healing and shamans, moves them along that pathway so that they have a joint shared experience and a joint resolution. So that's going to take a lot of training. So we actually train these service users in about 8 to 12 day-long sessions about creating stories, and stories that are going to be impactful, stories based on their own experiences, but helping them to put them into this narrative arc to help move the healthcare provider along that affective pathway together. In addition to the basics of photo voice and kind of learning how to use a camera, writing your narrative arc story, we also teach them some of the basic skills around public speaking, issues of confidentiality because they're going to their homes and taking photographs, distress management. These are still people living with mental illness. We don't want to make the situation worse by involving them in the process. Disclosure, how do you talk about living with a mental illness to people you haven't before? And then also, because we're going to have these individuals like me show up at a primary care workers training, we have a question and answer session, and so they need to be able to tackle difficult or sometimes stigmatizing or judgmental questions. So the process in photo voice is to get individuals to look at an image and to be able to kind of have a mentalizing of what others might see with this. So the way that we use these 12 sessions is to kind of walk them through, when you take a picture, what do others see? What is that joint emotional experience? And we have them do it in these 3 stages of what is it like to live with a mental illness, what is it like to have the experience of getting treatment, and what is the benefit? What is the impact after you've gone through treatment? How does your life look? And so one of our service users said, oh, it's like a butterfly, that you start out as kind of a caterpillar, a good functioning health system is like a chrysalis, and then you come out and you're a butterfly. So that's often how they would frame their stories. All right, so let's take a break and kind of throw this out to you for a moment. So this is one of the first photographs that we asked an individual living with mental illness to take a picture of. So I just want to see, as part of the photo voice process, the service users talk to their co-trainees, other service users, about the photos they've taken and get feedback. So I just want to throw this out to you. What do you see in this picture? What's your interpretation? With no context given, what are you picking up? Throw out anything.
I'm a psychiatrist, so restraint.
Okay, great. So we see some restraint there. What else do you see?
I thought she was stretching.
Could be stretching. Great. There are no wrong answers here. The idea is to try and just get a sense of what are you picking up from this image?
Probably like a sociogenic, non-organic seizure type thing, like a possession.
Which is very common in Nepal. I'm not going to say yes or no to this, but that's very common.
Why is the little girl laughing? Is this a posed photo?
Another great point. What else?
A game. A game.
Like they're playing a game? How about any of you? What do you see? What's your reaction to this photograph? Confusion? What do you think?
If the mother wouldn't be there, I would also say they are playing, actually.
How about else? What do you see?
Yeah, it's from the person smiling. I would think that it's a game of some sort.
Okay.
Well, no one looks too distressed about her being on the ground, so I would imagine that whatever's happening is what they're familiar with, or it's not a serious situation.
Other ideas?
I'm wondering if they're used to doing these kind of things. The 2 girls on the side seem used to this kind of situation. The way they hold her.
Great.
I also just thought children were playing.
I mean, I thought that the girl in the middle had like fainted or something, but it looks like they've already developed like a strategy, like you take one side, I'll take the other.
All right. Now this picture. What do you see? What do you think you see?
Decomposition of organic matter or something.
I like it. I'm going to write that down. Okay, so decomposition of organic matter. What else?
Cloth?
Cloth, okay. Nice cloth, fancy cloth?
No. Torn up, decomposed cloth.
Decomposed is a theme that's coming out here. Okay.
Shredded.
Shredded.
I wondered if it was a corpse or something, but it's also, there's like, some looks like cloth and others looks like it could be like large plant leaves, like palm fronds or something.
Uh-huh.
Probably just cloth, but there's some kind of ambiguity.
If this were southern, this is southern Nepal, just north of where you work, so what would this look like? What would you guess this would be?
Yeah, I wonder if maybe it's someone preparing to be cremated or something. I don't know.
It's kind of a death theme.
Something, yeah.
Other ideas?
It's hard to tell what's under it.
Okay.
But yeah.
Yeah.
I was just thinking of the shrines to cloth, because I signaled in my talk that you use it as a marker, but this is quite different of divinity or divine.
Other ideas?
To me, it just looks really natural. Dried palm leaves.
So dried palm leaves. Any other ideas over here? Anything else?
You're going to give us the answer right now.
So I'm just giving you questions. All right, another picture. What do you see?
Homeschooling.
Hmm?
Schooling.
Schooling? Great. What else?
Looks like it's at home. It's like families sitting together, reading together or something.
So families together at home, and maybe a schooling type activity.
This is a small home.
Small. Okay.
It looks like it's small because they're obliged to sit on the floor next to the bed to do these kinds of activities. So it's relatively small.
I think of these families I know in Rajasthan who they'll reverse the whole schedule of the family to make sure the kids are successful, help them achieve success in school. So I can imagine this would be a family helping, someone prepare for an exam or something like that. But maybe in a stigma reduction campaign, I can imagine maybe it's someone who has a problem, but they're also engaging in normal activities, trying to advance themselves in their career.
So that symbolizes to you kind of normal activities, but also the prioritization of the next generation of the children.
Something like that, yeah.
All right. Any other thoughts on this? From our students, what do you see here?
Looks like they're helping the children with homework.
Great. All right. And the answers are... So this is what people go through for weeks and weeks trying to create a story that is going to have a shared resonant experience to send a message to health workers. So what we very often find is that after the first week or 2 weeks, people go home and take literal pictures, kind of staged pictures of what it's like to live with mental illness. So as many of you picked up on, it looks like these two have been doing this before. So this is a girl with both depression and epilepsy. And so what happens there is when she has these seizures, so this is in Nepal, not in Liberia, where it's contagious, and Nepal, not contagious. So when she has these seizures, this is how the younger sister and the mom hold her down. But it's staged. You can see that the younger sister's almost laughing. The 2 pictures before that, she's totally laughing. Everybody's looking at the camera and laughing. And this is the one that's kind of closest to them trying to reenact it. But as soon as they put this picture up, I love our thing about a pseudo-seizure or psychogenic seizure, immediately everybody went to, well, what's the pathology behind this? Everybody wanting to diagnose, figure out what's going on, or a sense of it not being genuine, right? That this is being acted, that this is play. So it wasn't resonating with the rest of the group. And so the group learned, if I go bring this to a health worker, why would they believe this? This is like making it up, this is mocking. How am I actually going to emotionally connect through this image? So what's surprising is that after a couple of weeks of doing this, we start seeing pictures like this for a person to talk about living with mental illness. So this is a woman living with depression. And she took pictures first of like looking sad and kind of like selfies and this kind of thing. And then she came back with this. And so this is dried banana leaves. And she said, and I love kind of the decomposition theme and the hidden theme and what's underneath and all of these things, because she says this is depression. Depression is a dried banana leaf. It's totally useless. You can't do anything with it. You're brittle. You break easily. She didn't use the word decomposed. I'm not sure what the Nepali word for decomposed is, but she could have put that in there. So the idea of not useless and just broken so easily, and also nobody wants to look at it. When you're depressed, everybody wants to look away. So what we see is that suddenly these images become much more symbolic in nature and aren't kind of this literal of what it's like to experience mental illness. And I love all of your appraisals of this, because this is the same woman who did the dried banana leaves for the beginning of her story. And the end of her story, she did this photo to say, when I got treatment for my depression, I could suddenly be around to help my kids out with homework. And this was the symbol, just as Jeff was saying, of like, we are a good family. I am a good mom. The complete kind of opposite end of a dried, brittle, broken banana leaf is that now I can be there so that my kids succeed. And these are her 3 kids, all there together in a small home. They're low socioeconomic status, but she's helping assure for them success in the next generation. So she's a woman fulfilling her role in society. So what we see is that people begin to find ways to communicate with each other, to then take these stories to a primary care worker to say, pay attention to me because this is the type of suffering that I'm in. Now you can understand and connect with what that's like. You can imagine being a brittle banana leaf. And if you provide treatment to me, this is what we can do together. This is the impact you can make. Okay, so being empirical, that's all fun. They're nice stories, but we have to go and test it. So what we do is we take a 10-day WHO curriculum and we pepper throughout it these service users' stories of what it's like to live with mental illness. Somebody doing a narrative about depression, somebody about alcohol use disorder, psychosis, epilepsy. So let me walk through, this won't be a guessing game, I'll just walk you through one of the individuals' stories. So this is a man living with alcohol use disorder. So he just showed, in a much kind of literal sense to start things out, the place where he used to go to buy all of his alcohol. And he talks about kind of the addiction, wanting to go back there every day, spending all the family's money so that he couldn't spend it on the kids and the kids' schooling. The kids couldn't get after-school tuition because of him spending all this. So all the money just disappeared into this place. And then he took this picture. So one of the things was to get at this idea of violence, right? So you have the peril, stigma, that threat, to be able to symbolize violence without having to actually do a fake picture of looking violent or something that wouldn't feel sincere. So this is a window in the home. And when he was drunk one night, he took this device used to cut garlic and other chopping for cooking and smashed the window of his wife's kitchen, and then they ended up having to put up screen there because of the mosquitoes. But so what's important in these stories is that the health workers don't assume that we're picking totally rosy, unrealistic characters, but that individuals who have some of these stigmatizing behaviors, so that they take this seriously, that even somebody who got drunk, wasted all of his money, shattered windows in the home, was threatening towards his wife. And then he used this photo, and he says, this is a bridge between like my home and my professional life. Being able to cross this bridge, which was right in front of his house, meant that he could go out, be a man in society, earn money. But that when he was drunk, he would often go onto the wrong road. He would go onto the road with no sign on it, on his bicycle, fall off, and then end up in that ditch. And one time he even hurt his wrist, so he's a painter, he couldn't even go and paint after that. So he describes, I'm not moving forward. I can't pass along on the bridge of recovery. And then he shows these 3 women, and he refers to them as his 3 goddesses in Hindu divinity. One of them was a health worker who identified him in the community and said, we've had training about people who are using more alcohol than they want. Would you like to come in and talk to some of our people here? Then a health worker who helped with some initial medication for the withdrawal period, and then a counselor who did a form of motivational enhancement therapy with him over a couple of months to facilitate his recovery process. So he says, these are the types of people that heal. And he said, these are just like the people in this room. These are people just like you who had no prior mental health training. They got the same training you're getting here, and they came and they helped me. I refer to this as the goat sign. I can't count the number of service users who, kind of doing this all together and independently, we had multiple different groups, came up and said, like, they took a picture of goats. I said, okay, what's the goat thing? And the goats, they said, goats is economic productivity. That money that I wasn't spending on alcohol, I can now use to buy goats. And everybody knew that goats meant money, right? That goats were status in the community. You get milk from goats. You can, on one of the major holidays in Nepal, you slaughter a goat to share meat with your family and others in the village. But that this was a sign like, we are responsible. We take care of our money. I take care of my family. So many men and even women used this as their sign of their economic success. And then he said, kind of, rather than just show a picture of me not drinking, I want to take a picture of my house. He's a painter, and he said that when he was drinking, his house was always gray on the holiday. This is actually around Holi. So right around Holi, he would never do anything. But now he puts up these lights. He paints his house a new color each year, and he wants to show to the community, look, this is what I can do. But the most important photo, I think, of his whole experience is this one that he ends on. And he says, I'm a painter, my job was to go and paint houses. But when I was drinking, my hands shook so much I could do my best just to get one color on a wall. But now that I'm not drinking, this is a ceiling I painted for one of my customers. And he said, the customer told me, paint anything you want to, I just want something nice up here. And he said, so I painted these birds and a cloudy sky. And he said that we know that if it doesn't rain, we don't live. That you can put everything you want into the soil, all the seeds you want, but if there's no rain, that soil, those seeds aren't going to grow into crops. But when it rains, we know that there's growth, that things are in the ground, that are hidden, that are underneath, finally come out. This is what living with mental illness is. We can try our best, we can do what we want, but we are seeds stuck in the ground. And if we don't work together to get the rain, to get help from you from above, again, going to a little bit of the power and the hierarchy complex of the health workers, if we don't get that help, we will never grow from a seed into a healthy crop that is going to be useful for the community. So when he tells this story, suddenly all the health workers are like, I can do that, I can make a difference, I can make this change. So the ability to symbolize what his life is like after recovery versus just a literal come up and tell you a story, we saw, okay, people seem to be getting this, people seem to be investing. So we suggested then that by using these stories, we were doing this intergroup contact. There you see a picture of one of the guys showing his story. We're reducing threat and anxiety by having these people spend time together, get to know one another, personalize them. We're promoting hope with the idea that if you get treatment, you're going to get better. And by saying, like, here are the 3 goddesses that provided my care, you're also saying that you as a health worker can go and make this different. So we then wanted to evaluate this and see if it was producing the changes we intended. So we did standard self-report questionnaires. So this is stigmatizing attitudes as measured with the social distance scale that I mentioned from Liberia earlier. So it's the idea of, you as a health worker, do you want to spend time with other people living with mental illness? Would you be willing to treat them? Would you be willing to have them as your neighbor? Would you buy something from them in a shop? And what we find is that after the training, they definitely have improved attitudes, but this continues for months. Over almost a year and a half later, there's a significant difference that's maintained after you've heard these stories. The next was this idea of kind of getting away from that subjective incompetence, that idea of helplessness. Can I make a difference? So this is relatively small in terms of the actual difference, but it was significant in terms of after the training, more individuals felt like they could make a difference in people's lives, and that was maintained, again, almost a year and a half later. what about the impact on patients and providing care? As I brought up in the beginning, we think stigma is blocking people from actually providing these services. Is the service delivery actually different amongst the individuals who have received a WHO training with these service users sharing their stories? So we found first that they were seeing more patients. So for every 3 patients seen by an individual in a general WHO training, there were 4 patients seen by those individuals who had the reshaped service users. So they were seeing more people. They were diagnosing more people with mental illness. We then looked at the health facility level, and we found that across health facilities, of the 16 that we trained in a standard WHO manner, only half of them a year later was still providing services. The other half weren't even doing mental health care. Whereas 13 out of the 16 in the arm that received that training that was no different in content except for the service users were actively seeing new patients. What we were surprised to find was that the accuracy of that care was also much greater. So that in the cases of these individuals receiving a general WHO training, only half of the patients were correctly diagnosed. So they're seeing fewer patients, and more than half of those are incorrectly diagnosed, compared to in the reshape photo voice arm, where almost 3 out of every 4 were correctly diagnosed. And what's interesting is seeing where that difference lies. So this incorrect diagnosis amongst standard WHO-trained individuals is that 1 out of every 5 individuals with depression that were diagnosed was an incorrect diagnosis. So you're coming in, maybe you're grieving, maybe it's something else going on in your life. You don't actually have depression. We did all the validations with psychiatric interviews. You don't actually have depression, but a primary care worker thought you did. But the most alarming was that for every 3 diagnoses of a psychotic disorder, 1 of those was incorrect. So an individual is getting started on haloperidol or risperidone or olanzapine when they don't even have a psychotic condition. And what we think is going on is when this general training happens, you're kind of lumping all of these things together. Mental illness is just one big thing, and so it doesn't matter if I call it psychosis or depression or whatever else. Now, if we look at those that actually heard these stories and went through kind of this narrative emotional arc together, what we find is that 1 out of every 20 with depression in terms of diagnoses was incorrect, and 1 out of 5 with psychosis was incorrect. Still not great from the psychotic perspective, but much better than the other arm. So what's happening is that those individuals who have gone through that experience together with the service users, they're more accurately diagnosed people living with mental illness. There's some kind of resonance going on in that experience that allows them to be a more effective clinician. So how do we tease apart what might be going on in that scenario? So one of the things in terms of doing global health work is from a traditional anthropological standpoint, I've always been trained with the idea of you kind of have lab-based studies and then you have the field-based studies. And the expectation is you sit, you watch, you observe, and you kind of see what comes along, and that's your research. So what we've now tried to do is to say, how do we create simulated scenarios of an interaction with a stigmatized person to try and tease out what might be going on in that situation, rather than having to sit around and do long-term ethnography, which is very important, but not always so feasible. So we've basically adopted techniques used in general medical education of like an observed structured clinical evaluation, where we have an individual, a health worker with mental health training, usually a counselor, act out living with depression or psychosis or alcohol use disorder, and then we have a 10-minute role play where they spend time with a primary care worker, and we look and we observe in that interaction. And we're not just trying to get the idea of, do you want to spend time with them, but what's your body language say? How are you reacting to them? Do you have good nonverbal communication in terms of how your posture is? Are you paying attention and what's going on? Are you answering your phone in the middle of that clinical evaluation? Are you reinforcing what that individual is saying? Are you stigmatizing them? How much time are you giving them to talk about their experience? So it's a little encapsulated role play. And we developed these role plays by drawing upon the existing mental health literature, but also by working with local healthcare providers to finding out culturally what are those things that signal investment and caring and wanting to be involved in a mental health service versus being dismissive and stigmatizing. And then one of the big challenges, again, goes back to this idea of shared vision, is are we picking up things that could be rated equally by me as a Western mental health professional and somebody who's locally from Nepal? Are we seeing similar things? So having kind of a shared vision of the role play. And we've done this in multiple different countries, but a key thing also was making sure that we had local health professionals that were pointing out, local counselors, pointing out what types of things they wanted us to pick up on. So one of the issues that we saw was that people weren't creating kind of realistic hope. That in these healthcare encounters, it was always the idea of, you'll be cured, you'll take this medicine for a few days and everything will be just fine. And so an important thing to show kind of respect and that I care about you and I hope to see you back is that you might not get better right away. This is going to take some time, but I'm here to support you in this process, as opposed to this is a 3-day antibiotic to cure, lifelong psychotic condition. Another issue was that the idea of actually incorporating the explanatory models into that discussion. Are you actually asking a patient how they're viewing this process? So we added in specific Nepali ethnopsychology or Liberian ethnopsychology into that discussion. And then also the idea of trying to get away from the whole session just being advice giving and being more of a listening encounter so that there's a dialogue back and forth. And in retrospect, this is probably one of the important things with regard to if I'm in more of a listening stance after having heard those stories, I might actually get the information I need to produce the correct diagnosis. So this is what we see when we run these standardized role plays. In the reshape arm, across most of the conditions, they're more accurately diagnosing these standardized patients, the patients these counselors that are acting out the roles. Interestingly, the only one where it was different and wasn't statistical was an alcohol use disorder, because the trained individuals came back and said, well, we know they're drinking, but it's underneath because they're depressed. And so we actually need to get at that depression, and we can't just tell them to stop drinking. So I don't know that that's exactly a wrong answer. But the nice thing is that this strongly associates then with what we were seeing in the actual clinical patient care. This is important because we can't measure every single patient encounter. We need ways to kind of simulate these experiences to look at these behaviors related to empathy, rapport building, therapeutic alliance outside the context of a clinical settings. And so these two were rather strongly correlated. Just to show that we've been able to find similar things in other settings, we've also done a 3-country pilot, Uganda, Liberia, and Nepal, using some similar approaches, evaluated these kind of self-report aspects of behavior change after going through the training. And then we also looked at these role plays, the role plays called the enact. And what we found here was that the most strongly associated aspect in terms of a self-report measure with the enact behavior, with the role play behavior, was the level of social distance, was the stigma. And in particular, people who had lower levels of stigma that went through these kind of photo voice-based role plays, they were more likely to ask the patient about their explanatory model, their causal model. They were more likely to actually ask the patient and the patient's family about recent life events, about other health issues, not just the mental health, but then to ask them are there other things going on. And they were more likely to actually engage the family in these, and this is all just in the role play scenario. So it points towards that we think this approach of reducing stigma is allowing them to get more information to produce actually appropriate care. So from a neuroscience perspective, one of the things we wanted to look at is can we actually see any differences in a kind of a neuropsychological test? So who in the room has done an implicit association test before? Who's done one? Okay. So for those of you who haven't, it was used in the last political campaign in the US, and not to anybody's benefit, I think, but it's the idea that there are biases, and if I ask you, do you want to spend time with someone who's of a different race, of a different religion, of a different political party, of a different gender, that you're going to tell me the social desirable response. And the implicit association test is a computer-based test where it looks at response time to help tease apart kind of the social desirability, just answer a question and response, versus how you pair concepts in your mind. So there's an existing implicit association test for mental health. We adapted that in Nepal and Ethiopia, and we're now doing it in Tunisia, China, India, and Lebanon. And what it allows us to do is to try and see, are there implicit biases of these health workers associated with mental illness versus physical illness and risk of violence? And there have been a number of IAT studies that have been done using functional neuroimaging to get a sense of what is activated. And this is consistent with a lot of the pathways that are also activated in terms of threat and discrimination. So back to Jeff's talk from this morning, we use a lot of similar approaches in terms of free listing different concepts related to mental health, physical health, violence, nonviolence, burdensome, non-burdensome, to come up with a culturally appropriate implicit association test. We then program that so that individuals can use it on a laptop computer. This is the adaptation process in Ethiopia. And what we find is that the implicit association test has moderate correlations with the self-reports, and that's kind of what you expect. The idea behind the implicit association test is also that it's tapping into other unconscious processes beyond just the self-report, so you don't expect it to be a one-to-one outcome. So we tested all of our health workers prior to going into the training to look at when they came in, what was their implicit bias level, what was their mental health knowledge, what was their level of self-reported stigma, and then how were they performing in these clinical scenarios. And what we found is that when you control for the different types of vignettes, that the most significant predictor were these unconscious biases. Those individuals who are more likely in an unconscious fashion to associate mental health with somebody being violent and physical health somebody being nonviolent, the more you had that bias, the less you had an empathic, engaged, therapeutic encounter in these simulated role plays. Now, what's interesting, though, is that after the trainings, these associations don't hold. So when we go and do IAT at follow-up and we do the enact role play at follow-up, the associations are not present. So to wrap up, I just want to be remiss if I don't also talk about structural conditions that are also involved. So one of our more recent studies, both in Ethiopia and in Nepal, is to also look at how can we tell at the health facility level, are there aspects of how a structure, a system, policy, funding might also influence these behaviors. So this work is in its early stages, but it's the idea of we can't just think about individual behavior change if the system isn't also being modified. And this is kind of our theoretical model in which you might improve knowledge, explicit attitudes might change. We're not sure if implicit attitudes change, but then ultimately the setting where you're delivering care is going to influence how that care has quality and ultimately the patient outcomes. So we did qualitative work to get a sense of what the different types of facilities were and potential barriers. We then developed a vignette-based system of if a patient with X symptoms showed up in your health facility, what would the diagnosis be? Do you have the treatment you need available? Did you get training in this? Do you have supervision? And would you document this for the health system? So this is our data from Ethiopia. So what's interesting is that historically, if we think about stigmatized conditions, TB is one of the worst. The white plague, right? You got to go away to a sanatorium. So from a historical medical perspective, TB is a highly stigmatized condition. If we look, though, at kind of social distance related to people with TB in Ethiopia, it's very modest. It's no worse than somebody who has diabetes or a woman who is at risk for preeclampsia. So TB wasn't really stigmatized, but it should be. It's contagious. It actually, if I spend time with you, I can get that, and if I'm not treated, I can die. So it should trigger all of those things related to stigmatizing threats. But if we look at the resources that are available for TB compared to other conditions, even though accuracy of diagnosis isn't that much different, a touch better in TB, but the medication's available. They have to do record keeping and report this to their bosses who have to report it to their bosses. There's training and supervision regularly available for TB. So what we see here is a condition that has been highly funded by the global health community through the Global Fund for HIV, AIDS, malaria, and TB. There's a lot of resources that go into this process. So health workers don't feel incompetent. They don't feel powerless. They feel like they can actually make a difference because they know the protocol. It's not that hard. They can recognize it. So what this shows is the other arm of our work to try and think about those things that drive stigma is that we need to also change the setting under which people work to lower anxiety, to lower threat, to increase that feeling of hope and competence. And hopefully at one point we'll get to depression, alcohol use disorder, and psychosis being just as well resourced as tuberculosis. We just have to tell the donors that it's contagious, like TB is, and then they'll fund it. All right. Okay, so just want to wrap up and then take some questions. I think what this is pointing towards is that we need to think actually about what the motivation and affective reasons are for why people interact with others, and that social neuroscience can teach us a lot about this. And simply telling you that a condition is in your brain, is in your head, is in your genes, that's not changing how I act. But if I can use social psychology, medical anthropology, and social neuroscience to rethink my training programs, my supervision programs, how I'm trying to get you invested in this process, there's great use that social neuroscience can have at that area, not at, well, it's because of your dopamine or it's because of your serotonin. The other is the importance of developing these alliances with service users. So Jeff talked about the importance of his collaborators. Another important type of collaborators are those individuals who are ultimately going to benefit from your research. How much are they involved in that process? So that's been very important for us, that we work alongside them, and that allowed us to be able to then help them create these stories, these very affect eliciting stories to be able to train the health workers and produce the changes that we're seeing. And that the other kind of longer term vision is that we need to think about changing structural conditions, because even if we create a positive experience, get you affectively invested in providing care, if the conditions aren't appropriate for you to be able to do that, ultimately we anticipate that stigma is going to come back and that things are going to get problematic again. Here are just a few resources. The US NIMH did US NIH and the Fogarty Center did a special issue of BMC Medicine a couple of months ago on stigma research and global health. It has a number of great both theoretical and practical articles. Those role plays that I mentioned, we are now, WHO is interested in them, and so we're now going to have a global platform for people in different settings training health workers to use these role plays to be able to look not just at what is your mental health knowledge, but how do you actually interact with people and how do you adapt those role plays in different settings. And just want to end with this. So 2 days on Tuesday, so 3 days ago this week, we held our final dissemination event with the service users in Nepal. So we trained 29 different service users in this area of southern Nepal. And these are just 2 quotes that came out of the feedback from the service users. So one was a young woman who said, "We could never speak up in front of even 2 or 4 people. After coming here and taking the training, we've been able to speak in front of the mass. After seeing changes in us, others come up to us and ask, 'What happened to you? You were not like this before. How did you improve so much?' We tell them about this training and about the treatment provided by the health posts." So we have our nice kind of liminal arc there. These individuals who were outside of society, went through a healing process, are now back in it. And then a young man who said, "I couldn't even say my own name in front of other people, but today I can go in front of health workers and talk about my story. I'm proud of myself now. I am now confident to even MC programs without feeling shy." There are also, there are a number of limitations, a number of challenges, but I think these quotes help to illustrate the responses that are being elicited in the service users and how that can be hopefully positively contagious towards the health workers that care for them. So thanks for your time, and I've got like 15 minutes for questions. Yeah, please.
Hi, thank you for this great presentation. I have a question about, I guess, the language and possible unintended outcomes of sort of anti-stigma programs. I read a very interesting paper just 2 days ago called "Bullying the Bully" about how basically zero tolerance anti-bullying programs in schools sometimes like backfire in all kinds of interesting ways. So I'm asking this question as an evolutionary anthropologist, interested in and concerned with coalitional psychology, in-group and out-group processes that I understand are quite universal to the human species. So what we call stigma in this context is, I guess, in any group, there's going to be a group of people. It could be an ethnic group or a group of people with illness who are going to be symbolically marked as some kind of taboo entity. So often I wonder if instead of calling things, anti-stigma, we could call it sort of like the pro-acceptance. I'm thinking also of like anti-oppression programs on college campuses that sometimes turn into some kind of a witch hunt against people who are, perceived to be oppressors, but haven't had an opportunity to participate in a conversation where they feel they belong. So some people have pointed out that the rise of the alt-right, for example, is sort of co-constructed with the campus alt-left and that sort of thing. So I'm wondering if you have any stories to share on how some participants might not have reacted well to this idea that you have this dirty stigma in you. You're the stigma person, and have you noticed any kind of potential witch hunt or people?
Yeah. So I've actually probably in trying to describe this work and also get feedback from others, especially in high-income countries, have heard a lot about problems when this has been executed here, and that sometimes activities and groups like NAMI have had very beneficial outcomes, but in many cases, when I look at a fair number of my colleagues in psychiatry, they're very hesitant towards engaging with service users because they just feel like it's going to be an attack, right? That you're going to come and you're going to talk to me about all the things that I'm doing wrong. And when I was briefly went over, we tried this work in Uganda and Liberia as well. And in Uganda, we couldn't do it in the same way because the service user organizations had all been funded by the UK, predominantly from survivors of psychiatry movements that were, I'm not going to take medicine, you're controlling me. So when we tried to have them go through this process and talk about it, it's like, no, I'm going to get up and I'm going to lecture that health worker about how I don't need medicines, this is just because you're discriminating against me and da-da-da, and if you weren't, then I would totally be fine. And, if you look at online, there's a lot of anti-psychiatry issues. So it was important to us that this not be an accusatory process that then, because if we go back again to the neuroscience part of it, if you want to do stigma, you don't have people feel more threatened, right? We should feel comfortable interacting together for that to work. So that requires a lot of crafting. So on the one hand, I think we're doing, at least in this project, a good job about meeting a health worker where they are and being able to say, this is in this together, this is going to be a jointly beneficial process. At the same time, it means, what do we do if a service user comes to us and is going through the process and every picture they have is they want to, something awful about health workers and how they ruined their life or their spouse's life or somebody else's life? We need to figure out how we're going to address that. So what we're doing at this point is we have a second phase to this process that once health workers have been trained, the photo voice is about quality improvement and about the meds aren't available or the doctor's not there or these things that are more problematic towards how the health system is going. But the idea is first we've already come to the same page and say we both want this to work in the community. We want you to be good health workers. We know this care is important to us. We need you. Then we get to that point of giving feedback about where the system's not working and we're trying that out. So we're just in the initial phases of doing that in Nepal. In Ethiopia, it's really problematic because of the legacy of communism and that the health workers were basically, or socialism, the health workers were expected every month to appear basically just in front of a chair, in front of the whole community, who kind of uses that health post. And they weren't allowed to talk. And the health and the community just got to say what was wrong with the health facility. So when we introduced the idea of, we could get the people in the community to take pictures and come tell you about what's wrong and what's not working, they were like, no way, we're not going to do this because we already deal with these monthly, basically public costings. So there we had to find other ways to have people share their messages in private, separately, and try to develop more coalitions. So I think there is huge risk to this being interpreted as, you're doing these things wrong, you're incompetent, da-da-da-da. And so we have to frame it around, this is a shared journey, we have a shared goal, how do we work on that together? And then also find ways for other voices to come in who are going to be more negative about that experience.
Briefly, because my concern was not only about the potential paternalism, cultural paternalism, but also because I think the average human mind is not very competent at handling, difference and nuances. But people like to be told who their enemies are. So my question was also: have you noticed perhaps a growing culture of recent converts to the anti-stigma culture, who are then calling out other people and telling them, you're this bad person because you do the stigma thing, and does that increase conflict in the communities?
So that's I think where I think these neuroscience models can be helpful, and kind of the kind of briefly went over, but this idea that stigma is a normal function of normal brains. Where does it come from? And so what we do is we have a module where we have them first talk about what are other types of stigma in society, and they go to gender, they go to caste, they go to age-based discrimination, so that everybody does this. Even if you're a person living with mental illness, you're probably still stigmatizing against somebody else in some way. So if we make stigma a normal human process, then that's something we can work on together, as opposed to I am always victim, you are always perpetrator. So those are the things that we're trying to feed into it. But now that you raise it, it makes me think what even more can we do about that as we watch how these groups progress after the initial trainings? Yeah, thanks. Thursday?
Thanks so much, Brendan. This was really fascinating. I would be curious to hear a bit more about what kind of role the service users who are being trained in this way take in this process. Are they sort of being semi-professionalized, or is there, how do you create a collaborative spirit to say, we're all in this together, we have an incentive to improve the services? Could you speak a little bit more about what is the incentive for the service users to participate in this process? And are they sort of joining the workforce or the sort of healthcare worker force in the moment they're being trained and sort of incorporated in that? And does that create new divisions in the way?
Yeah. So Liberia and Nepal are very different examples of that. So in Liberia, there's a strong, growing, official service user movement, and it's called Cultivation for Users' Hope. And it's started by service users with originally funding from the Carter Center, but now they apply to outside grants. And it's the idea of, again, back to agrarian things of we grow things, help us grow together, help us work together. And what they do is then try and establish other little satellite groups throughout different parts of the country. And they've been very, very successful doing that. And again, they come at it very much from a collaborative standpoint with the health system and with the government. Their biggest opposition were the disability rights individuals in the country, because they said, we don't want mental illness people to show up at our disability rights meeting with blind people or deaf people or other types of disabilities, because it's going to give us a bad name. So they had to kind of work long and hard to find a shared alliance with the other disability rights movement, because they felt like they're going to bring them down. But it is pretty professionalized. They now regularly meet with the ministry to be able to provide their input. The idea is the ministry has to take into account what the service users are providing too. So I think there is a semi-professionalization going on there. In Nepal, it hasn't taken off in that same way. The government now has put forth in the new mental health policy they're trying to institute that there should be supports for community-based service user organizations. However, going back to kind of sharing with the health worker administration, there hasn't been a lot of acceptance of them coming into meetings and giving feedback about the health system. So they have not been semi-professionalized in large part just because I think resistance amongst practitioners and even more so amongst administrators. But at the same time, there's this appeal to we want to look good from a WHO standpoint and all the recommendations about service user representation. So I think it's going to be an interesting journey that's going to go back and forth in that setting. Yeah. Jeff?
Yeah, Brandon, thanks. It was great to learn more about some of these things you're doing with stigma reduction and other things. I was curious, that last photo you had, those were the mental health outreach people, right?
Yeah.
It wasn't clear to me. It sounded almost like you were describing some of them as patients who had received care, but that's not the case. That's like the team of the mental health.
No, these other than these three
these are people.
and him, the rest are all service users.
Yep.
So these are all the individuals who, or their caregivers who went through the trainings. We had 3 batches of training, so in total there's 29. So these are all the individuals who then now go to the trainings and share their experiences. These are the individuals we're trying to get to meet with the health policy makers and other individuals. So those are all people living in recovery.
I see, because it gave me an idea that, you know, as you know, in the like the spirit medium and the shamanism literature, there's this notion of a healed healer.
Yeah.
And I was just curious, and I would almost like to see like some of your experimental methods along this line. You know, could you engage people who have recovered in some sense, right? And you know, and then maybe something about that experience would certainly lend them more empathy for patients, and maybe more skill in kind of connecting, so they'd be less at some of the risks that you're talking about with stigma and all that stuff. So I'm just curious, is that something you've thought about with like engaging a kind of healed, recovered patients as new members of this outreach team, and maybe even testing if some idea, are they more capable like health service providers because of their experiences?
Absolutely.
Yeah.
So I mean, and that's a idea we're hoping to go towards.
Okay.
Because going back to kind of the evolution of empathy, and even what you see kind of in non-human primates, right? That one of the key part of this is the kind of this cognitive perspective taking, and the closer an individual is to somebody else's experience, the more likely that emotional contagion is going to occur. So, as like a white American psychiatrist coming in, I'm as far away as kind of possible to then do that. But then even a professionalized health worker in a health facility delivering you behavioral activation therapy or motivational enhancement therapy or cognitive behavioral therapy, there's still a gap there. Part of that gap, right, if we look at shamanic literature, is good, right, because you carry this power, so I think you're powerful. But from an empathy standpoint, you're not tapping into the empathy piece. So what we hope to do is to work with them kind of then as peer service providers, and hopefully in kind of cascade-based chains of that. The guy who tells the painter with alcohol use disorder.
About that, it could be a win-win situation. I was just thinking about him in particular. It could be a win-win situation.
So he's been great at getting.
He's cured, in some sense, and now in helping others, it probably helps him maintain sobriety and things like that.
Absolutely, and so he's already been referring people and really wants us to give him training.
That's interesting. Yes.
And the woman that he pointed out, I think, did a great job with doing the motivational enhancement therapy, but we found that other individuals within the healthcare setting, they often don't have time, or they're not quite getting the experience, they're not quite as believable in delivering that. So I think that individuals to go from kind of the healed to healer is absolutely crucial to this process. And also going back to kind of the empathy literature, training an individual on self-regulation actually seems to be less effective than if you train them to deal with other people's distress. So if you're distressed, you come in and they just had, grant didn't get funded, right? And then I come and I just sit down with you and try my best to talk through it, that seems to, for me, improve my self-regulation more than if I just sit there and say, oh, my grant didn't get funded, and how am I going to get myself to do that? So not only will it be kind of helping them stay sober, but probably even some of these underlying psychological distress factors may improve through the experience of providing care, assuming they're well supported, they're in a good structure, they're paid, and that is not big burden and burnout that then leads to exacerbation. Yeah, but I think that's a perfect model.
I'd be really interested to see where you take that.
Well, and I would love to do the CTRA with these folks, right?
Sure.
And look over time, does this also change?
It's definitely it's a great kind of psychosocial wellness, which would play into this, I would imagine.
We done 12:30?
Yeah, well, thank you so much. Very inspiring work, and I hope it will lead to many reverberations through the people here. And we'll take a break for lunch. We'll be back here at 2.
Thank you all. And if anybody has questions, feel free to come up.